In this video, I will explain the branchial cyst. A branchial cyst develops from the vestigial remnants of the second branchial cleft, is lined by squamous epithelium and contains thick, turbid fluid. The cyst usually presents in the upper neck in early or middle adulthood and is found at the junction of the upper third and middle third of the sternomastoid muscle at its anterior border. It is a fluctuant swelling that may transilluminate and is often soft in its early stages, so that it may be difficult to palpate. If the cyst becomes infected, it becomes erythematous and tender, and the differential diagnosis is broadened. Ultrasound and fine needle aspiration both aid diagnosis and treatment is by complete excision, which is best undertaken when the lesion is quiescent. It passes superficial to the hypoglossal and glossopharyngeal nerves, but deep to the posterior belly of the digastric. These structures and the spinal accessory nerve must be positively identified to avoid damage. In patients over 35 years of age, a high index of suspicion for a necrotic metastatic lymph node should exist and malignancy should be excluded before excision. Now I will tell about the branchial fistula. A branchial fistula may be unilateral or bilateral and is thought to represent a persistent second branchial cleft. The external orifice is nearly always situated in the lower third of the neck near the anterior border of the sternocleidomastoid muscle, while the internal orifice is located on the anterior aspect of the posterior phaseal pillar just behind the tonsil. Although the anterior aspect of the tract is easy to dissect, it may pass backwards and upwards through the bifurcation of the common carotid artery as far as the pharyngeal constrictors. The internal aspect of the tract may, however, end blindly at or close to the lateral pharyngeal wall, constituting a sinus rather than a fistula. The tract is lined by ciliated columnar epithelium, and, as such, there may be a small amount of recurrent mucopurulent discharge onto the neck. The tract follows the same path as a branchial cyst and requires complete excision to avoid recurrence.